Bhopal for having me here. Vaijanti and Shashi and Madhuri and Manisha and esteemed chairpersons for sitting through this, all of it, and all of you here. So I'm grateful that you're still here for another lecture on lipids, but I'm going to speak on understanding lipids, the abnormalities, and how to do a risk assessment for CVD. So a little recap about cholesterol, which is a fat-like molecule. It is not water soluble. Therefore, it has to travel in blood bound to lipoproteins. Cholesterol has a very important role to play in the body, and the body makes all the cholesterol that is actually required. But some amount of cholesterol is also sourced from food. This doesn't work, I think. It is sourced from food. So in case you have a very high cholesterol level, then you know which things to do. You have to reduce your dairy and your animal fat. The total cholesterol, thank you. ये नहीं work करता. The total cholesterol, is it working?
The mic is not working.
Take this, no? The total cholesterol. So the total cholesterol, thank you. The total cholesterol is actually the serum cholesterol and its lipoprotein carriers. Now you can do it by LDL plus HDL plus that equation, which is actually represents the VLDL. So you want to find out your VLDL, you do triglycerides divided by 5. But practically speaking, your total cholesterol is actually a balance between LDL and HDL. Now, all lipoproteins, whatever they might be, they have a hydrophobic core, which contains triglycerides and cholesterol esters. Now, which one a particular lipoprotein contains will identify which lipoprotein this is. And it has an amphipathic surface. This is also known as amphiphilic. So it means that it has a water soluble or it likes water, one pole, and one pole is hydrophobic. Because of these two poles in that same molecule, it can actually travel as a lipid in aqueous solutions. So it has a surface which is phospholipids and free cholesterol. These, the ones in red, are actually the lipoprotein, the lipid part, the lipo part. The protein part in your lipoproteins is apolipoproteins. Now there I have mentioned VLDL, IDL. IDL is intermediate density lipoprotein. So you haven't heard about this because this is just a remnant molecule and it is very transitional. When VLDL is metabolized to LDL, it goes through that particular phase. So what are the difference between these four lipoproteins? The differences lie in the triglyceride and the CE ratios. These ratios are different in them, and the lipid and the protein ratios, because the protein actually is the one which will give it density. So the more protein you have in the lipoprotein, it will become more dense. Therefore, HDL is the one which is high density. It has the highest amount of protein and the least amount of lipo. And the third difference is from which is the apolipoprotein type. What happened? No, I pressed it correctly. ये क्या हुआ? Okay. So the lipoproteins must understand that these are transport proteins. They actually are transport particles. Particles is the correct scientific word which is used for them. The low density lipoprotein is the main carrier of cholesterol. It can deposit the cholesterol and it can even penetrate the arterial walls, especially when it is small and dense. And this happens when it is oxidized. So when you have oxidative stress, this is how it converts into small dense particles. The LDL actually reflects how much of cholesterol is available to enter into the artery walls and on the surface to call the atherosclerotic plaques. And LDL is the main target for all lipid lowering therapies. Then you have the VLDL. This is the main carrier of triglycerides. This is also atherogenic. So you see the difference between LDL and VLDL. Now, the minute you add C to this, C refers LDL, C, HDL, C, etc. The C refers to the total cholesterol mass which is carried in that particular particle, which means it is the cholesterol esters which is in the core and the surface cholesterol. Then what is non-HDL? Non-HDL-C is LDL-C plus VLDL-C. Now you're adding these two atherogenic agents. Obviously it will be more atherogenic than either of them alone. Then the apolipoprotein, the protein part, is actually B100 and it is universally known as ApoB. This is the main protein which is embedded in LDL, VLDL, ILDL and even lipoprotein little a. Now there is just one molecule of ApoB which is there with each molecule of these lipoprotein particles, which means that increased ApoB is a surrogate for more particles. So whenever you see a particular value on your lipid profile report of ApoB, it is telling you that it is these many particles of LDL or VLDL that are there. Now, why is this important? This is important because clinically, you have a patient of LDL, say 165, but patient A has lower ApoB, patient B has more of ApoB. So the patient B has got more particles of LDL. So the particles, the number of particles is far more important than the actual cholesterol mass. Therefore, ApoB is a stronger indicator of atherogenicity than LDL alone. So then we come to HDL. This is seemingly non-atherogenic. It causes a reverse transport. So remember, this also carries cholesterol, but it carries cholesterol in a reverse direction from the arterial wall to the blood vessel. It helps to clean up the arteries. In case you have low LDL, why do you have low LDL? You have this in obesity, diabetics, metabolic syndrome, smoking, and sedentary lifestyle. So you want to increase your HDL because HDL is protective. So this is what you will attack. But extremely high levels may not be beneficial. Now, ApoA1 is the main HDL protein. Then we come to triglycerides. This is the storage form of fat in the liver, and this storage form of fat comes from sugars. It doesn't come from the fat that you eat. It comes from the sugars that you eat. So this circulates mainly in VLDL particles. High triglyceride is a marker of insulin resistance, uncontrolled diabetes and Met syndrome. But increased levels can lead to increase in LDL, therefore increases heart disease. Now, a word about lipid profile testing. Unless you have a family history of premature ASCVD or genetic hyperlipidemias, non-fasting profile testing is okay. So this is your initial lipid profile, and these are all the reference ranges that you can see. Total cholesterol should be less than this, LDL should be 60 to 130, and so on. And then these are the various ratios. Now if you have a look, I am re-emphasizing that LDL-C is atherogenic. It is a main therapeutic target. Triglycerides actually are connected to metabolic syndrome. Persistently high levels also increase cardiovascular risk, and very high levels lead to pancreatitis. Then non-HDL-C is a surrogate marker because see, your lab reports, many of them, good ones also, you tell them to do check my ApoB. They don't have those kits. So what should you do? The non-HDL-C is a surrogate marker for ApoB, which is available in all routine lipid profile reports. Then these are the risk enhancers. So you have ApoB, and it reflects the number of atherogenic particles. When should you measure it? If your triglycerides are equal to or more than 200. ApoA1 is the HDL protein, you want it high, but low levels are high risk for cardiac high risk, and ApoA1 cannot be interchanged with your HDL report because ApoA1 does not cover all the functions that HDL will do. So you cannot use it as a surrogate marker for HDL. Then you have the ApoA1 ratio, which is a good indicator of ASCVD risk. Then we have lipoprotein little a. The little a is different from the big A. Now this one is actually an LDL particle to which a small protein called apo little a is attached. So you see it is a double killer. It has LDL with ApoB and an ApoA. Because of this, it is an independent hereditary risk. It is pro-atherogenic, pro-thrombotic, pro-inflammatory. And in menopause, 15 to 25%, there is an increase of lipoprotein little a because it is not cleared from the blood well enough. This is a genetic marker. So I'm saying is that you're born with lipoprotein little a. So it'll start increasing by the time you're 2 years of age and reach a maximum by the time the patient is 5 years of age. So therefore this little a is not little anymore, and very importantly, it does not respond to all the therapies that you will do for reducing HDL. No lifestyles, no statins, unless you have PCSK9 inhibitors, which may help 15 to 20% decrease. Then you have high sensitivity CRP and homocysteine. Both of them are non-conventional risk factors. CRP you should do when you're not certain about what is the risk factor. Then you check for the inflammatory marker. Homocysteine. Now, in case you want to check, you have a family history. Which are the two markers which are very important if there is a family history or a personal high history? That is, you should check lipoprotein little a at that time and homocysteine. Then coronary artery calcium, this is done by a CT scan of the heart, and this is very beautiful. It gives you the Gatson score and amount of plaque, 0, 0 to 1, up to more than 1,000. So you can actually check what is the level of the subclinical disease by doing a CAC, but we can leave this investigation to the cardiologists. So one thing is very clear, that in the absence of a raised LDL, it is virtually impossible to cause atherosclerosis. Out of these 9 modifiable factors that we have seen here, dyslipidemia is the single most important cardiovascular risk factor. Now, okay, I am 30 years old and I have high LDL, so I'm pretty cool because I have another 20 years or so to go for my menopause. But if you have a lifelong exposure to high LDL levels, it will lead to earlier acute coronary syndromes. So take care of this even in younger patients. Now there are many risk scoring systems. We have often used Framingham risk score in the past. We don't use it anymore. Sometimes we use the Reynolds risk score in cases of inflammation, rheumatoid arthritis, psoriasis, and things like that. The WHO International Society of Hypertension, CRO, Southeast Asia region D. We come under the D region. So these are also these colored charts, but they're not menopause specific. Then you have the Q risk for UK and the European Society of Cardiology. These, and for the older population, OP, these are all adjusted for Europe. So they don't have much use for us. Then you have, look at this, so many societies have ratified this particular ACC, American College of Cardiology, American Heart Association, ASCVD risk estimator. This estimates the 10-year risk, and this is sometimes has been used so far. But then recently we had the Lipid Association of India, their consensus statement they said that Indians are different. So we are different, we have different lipid profiles than Westerners. We get disease earlier, more severe, poorer outcome. We need stricter targets. Now, if there's a clinical hierarchy, what will predict your cardiovascular risk? The first is the ratio, the second is non-HDL, and third is LDL alone. So the Lipid Association of India has given this diagram. It's very simple. It's based on risk factor counting. So what you have to do is, from this table, you have to just count your risk factors, whichever there are. 0 to 1 makes you low risk, then it's 2 major, it's moderate risk, and so on. But from this table, if you pick up any of the risk enhancers, then you have, if you add more than one, the low risk moves to high risk, and so on. So this is how this lipid association, it's a beautiful way to do it. But one thing about here is this estimation of the lifetime risk. This troubled me a lot. I didn't know how to estimate it. So if I have to give a talk, what will I tell you? I looked a lot for it. Only in one document of Lipid Association of India, they said that you can use the ACC-AHA risk factors for finding out this lifetime risk. But you remember this, that is on your internet. But just remember that if you have to do a lifetime risk more than the age of 60, it is not mathematically possible. So you can calculate a lifetime risk only between 20 to 59 years of age. So then this is another way to do it. This is very simple. So they have actually classified 0 to 1 major ASCVD risk factor and this, and this, and this. Moderate and high risk, they will say or this, or this, or this. So it's very simple to follow. Now for your convenience and for something which you can memorize, I've just put down the LDL values here. It's so loud, no? I put down the LDL values here. So it is 100 to 130, 130 to 159, and so on. So LDL-C is the single most important risk factor, and it's a primary target. So what is the target you need? Less than 100, less than 100, less than 70, and less than 50. So these are your targets. So these are the new treatment goals. You have to have triglyceride, HDL, and LDL according to these values. About LDL and non-HDL-C, you follow this table. So your drug therapy is recommended if your LDL is like this, in these various risk categories, or your non-HDL is like this, in these risk categories, and when you treat them, what do you want to target? These are the targets. It's a beautiful way to just identify how to do it.
Can we move
now,
on to the conclusion, ma'am, please?
Yeah, just 2 more slides. 2 minutes. Evidence
We are
shows,
really
is it dangerous to reduce your LDL levels? I was very curious. When I looked into this, so it says that 10 to 40 mg% is safe for patients, so don't worry. So the overall approach is that you must think of ASCVD prevention in your patients. Start young. How young? Start usually by 19 to 20 years of age. Some people say 9 to 11. Some people even say start at the age of 2, because especially in those people who have a family history, and screen especially these people connected to our speciality. And if you focus on these modifiable risk factors, you get the maximum benefit in ASCVD risk reduction. Non-pharma ways of lipid-lowering strategies, don't forget the therapeutic lifestyle change, triglycerides, diet and weight loss. But I want to mention that omega-3, we say, I am taking my flax seeds, I am taking my chia seeds, I am taking my walnuts. So I am taking adequate omega-3. But remember that if you have to reduce triglycerides, you have to take therapeutic omega-3. But LDL and lipoprotein little a cannot be managed like this. You have to actually give them therapy. So these all have already been talked about. Don't be afraid of statins. use them, and you can look at, like you talk about weight. If you reduce 5 to 10, if you say your 100 kilograms come down to 50, it's very frightening. Same is true for lipid profile. If you tell them your LDL is 180 reduced to 100, not possible. So tell them reduce in these percentages. So be safe, be responsible, be happy, and be kind.